Our next speaker is Jenny Pole. Jenny's been working within cancer services since 2013 after supporting her mother through ovarian cancer. She has found it rewarding supporting patients and their loved ones, working with a wide number of experienced nurses and colleagues. Over time, she found interest in stem cell transplant and was keen to explore and learn more. After a few taps on the shoulder with relieving in the role and increased hours with the health service available, she was able to work as a bone marrow transplant clinical nurse consultant since 2021. She is currently a member of ANZ TCT, and for those who aren't familiar with that, that's the Australian and New Zealand Transplant and Cellular Therapies Registry, and should be a member of a few more organisations. She really loves what she does, and like many colleagues, goes above and beyond to support as best as she can. So Jenny will be talking to us about stem cell transplantation. So take it away, Jenny. Thank you.
Thank you. I hope everyone can hear me. So it's nice to virtually meet everyone, and it's great to be able to speak to people directly who are keen to learn more about autologous stem cell transplants. And a special mention to Liam, who's going to be doing the slides. So next slide, please, Liam. So first-line therapy for myeloma involves induction treatment followed by consolidation treatment with an autologous stem cell transplant. And autologous means obtained from the same individual. So we're actually getting your own stem cells from the person. So research has shown an increased overall survival in patients with myeloma who have an autologous stem cell transplant in first-line treatment. So importantly, I guess my focus during this presentation is just transplant consolidation. It's quite a huge area. I usually spend about a good, sometimes up to an hour educating people. So I'll try and get through it as quickly as I can. Importantly, I'm sure a lot of people are familiar with the Myeloma Australia website. And so if people are considering a transplant, I would encourage you to definitely look at the Myeloma Australia Autologous Stem Cell Transplant booklet, a guide for people with myeloma. So there's a lot of really valuable information in that. Next slide, thank you. So my main focus is trying to briefly touch some of the following. So what are the advantages and disadvantages of an autologous stem cell transplant, proceeding to transplant, care and patient navigation, mobilising and harvesting stem cells, high-dose chemotherapy, reinfusion, common side effects and nursing care, and follow-up care. So the main advantages why we do transplants is that we want to consolidate the initial response from people's induction treatment. So I guess we want to put pause to the myeloma as long as possible. This is evidence-based. It does remain gold standard treatment. It is a safe procedure and it does improve people's quality of life and leaves behind a lot less residual myeloma cells. So the downside or the disadvantage of having a transplant is that people are going to get high-dose chemotherapy. This is a lot more toxic and it does increase side effects. There is a longer recovery, so it can be up to 3 to 4 months for a recovery. Not everyone will receive their desired response with a transplant. Fertility can be affected, and there is a risk of about 1 to 2% of death. So proceeding to transplant, these are the considerations that the treating haematologist that supports people through a transplant need to look at. So very much patient fitness, age and comorbidities. If you have an active lifestyle, if you have a sedentary lifestyle, are you independent with your own needs? Have you got issues with a physical or mental health disability? So there's lots of things that the transplant doctor does need to take into consideration. Another important thing is definitely having a dental review and assessment. Mouth care is really, really important. Some people may need to have repeat scans such as skeletal surveys and CT scans. There's quite numerous blood tests that occur, so people will need to have repeat protein markers and light chains. You might need to have 24-hour urine collections just to help monitor the response. Proceeding to stem cell collection, we need to go through specific viral marker testing as well. And sometimes the transplant consultant would like to have additional testing of either lung function test or a heart scan, or maybe a kidney scan or something like that. So care and patient navigation. So in regard to specialist appointments, a lot of the transplants need to be done at quite a large hospital. And so it's very important for a transplant physician to be able to assess you properly. You actually need to see them face to face. Consent will occur at this time, and of course it's always important to try and bring a support person with you as well. In regard to stem cell collections, majority of these treatments are attended as an outpatient. In regard to proceeding to a transplant, a lot of people actually need to be admitted for their transplant, and as a guided mission, inpatient missions, probably for about 2.5 weeks. Some people with myeloma don't live right next door or don't live too far away from a tertiary hospital. So in each state we do have patient travel assistance scheme. So there can be some people who actually need to travel quite a long distance to proceed onto stem cell mobilisation and transport and transplant. So support referrals include basically community-based organisations. So we have, of course, our Myeloma Nurses Australia. There is Cancer Council support, which is in each state and territory. There's the Leukemia Foundation, there's Rare Cancers Australia, there's the Arrow Foundation, there's Canteen that would be available to help if there's young people who have a grandparent or a parent that may be experiencing myeloma to help support them. There could be local charities relevant to your home state or district. There's a Look Good, Feel Better program. There is a new initiative called Carer Gateway, which is a service that does help provide support for carers. There's probably a few more that I can't recall, but there's definitely a lot of services out there to provide some support. Allied health referrals are usually in hospital referrals, but examples of these are social work, which I would encourage a lot of people to definitely be referred to. They can also assist with the patient travel. They're great at navigating issues with Centrelink, and particularly if people are needing to take time off work. There's the dietitian, there's physiotherapy, there's psychology. Some people are also referred to palliative care for support through pain management. And of course, there's Aboriginal health liaison officers, there's interpreter services. There's probably a few more that I can't recall either. Would always encourage everyone to have regular follow-up with their GP. GPs, of course, are getting a bit harder to get into, so your GPs will always continue to do your, sorry, that was my phone, to do your regular prescriptions and also pain relief. They can also do referrals to physio and psychology, particularly if your carer or loved one will actually need some additional help as well. A lot of people with myeloma do go on to prophylactic medication, and so the prophylactic medication is just to decrease your risk of getting any viruses or illnesses. And so two common medications that are used are valacyclovir, which is an antiviral medication, and Bactrim DS, which is an antibiotic which helps decrease the risk of having bacterial or fungal infections. And these two types of medication people will usually be on for quite a considerable period of time. Okay, so mobilising stem cells. So this is quite a planned and timed procedure. So it usually occurs after 3 to 4 cycles of induction treatment. It's very important to have good peripheral access for this. Sometimes people may need to have a central line inserted, which is either a permacath in the upper part of the chest, or might be a vascath on the side of the neck. There's two ways for mobilisation. So some transplant physicians will mobilise stem cells off cyclophosphamide and granulocyte colony stimulating factor, or GCSF injections. And then other transplant consultants may prefer just to use the GCSF injections and plerixafor. Our haematologists here usually use cyclophosphamide. And an example of how that is used is that we usually give cyclophosphamide on a Friday. So if we gave someone cyclophosphamide on Friday the 7th, the GCSF injections would start on Wednesday the 12th, and then we would actually start looking for stem cell mobilization on day 11, which happens to be today, which is Monday the 17th. In regard to GCSF mobilization, that usually those injections you'll have them for 4 days, and then the centre will then start looking for stem cells at that time. So side effects from cyclophosphamide are low blood counts, increased infection risk, decreased appetite, nausea, might have some loose bowel motions, you can feel a little bit fatigued. People will lose their hair. And the GCSF injections, so there are a type of growth factor that basically help the bone marrow produce more stem cells. And we want an overproduction of these stem cells. So if you imagine a bucket, and that bucket is your bone marrow, we want that bucket overflowing. And that's what these injections do. They help just produce lots of extra bone marrow and the little stem cells. And those excess stem cells will go into your bloodstream. The side effects of the GCSF injections are bone pain, so people can get some additional back pain, hip pain, pelvis pain, sternal pain, headache, temperature, and also some nausea. Occasionally, some people can get an injection site reaction as well. Plerixafor is a medication that is sort of a bit like a backup medication, and that can enhance the amount of stem cells being moved from the bone marrow into the bloodstream. There are certain criteria for that to be able to be prescribed, and one of them that you do need to start to have some mobilization or stem cell movement from the bone marrow into the bloodstream. If people are given this medication, most common side effects are diarrhea, dizziness, and headache. And for some people, they can actually get an upset tummy really, really quite quickly. Next slide, please. So apheresis and the stem cell collection process. So how do we know? So what we're actually looking for is that we need to do a CD34 target blood test. And the CD34 is a protein that's found on the surface of very early blood cells. So when people have a blood test, for example, this morning, the stem cell lab will be able to tell if mobilization has occurred. So once we have a certain number, we need a certain number to, to proceed for stem cell collection. People will have a cannula inserted in one arm, which is called the draw arm, and so blood will be removed. It will go through the apheresis machine. It mixes with an anticoagulant called citrate. There's a transducer at the bottom of the machine. There's a picture of the machine there on the slide, and that transducer spins really, really fast, like a washing machine. And there, the transducer splits and moves the stem cells up into a little bag, and then the rest of the blood product and the citrate is then infused back into a cannula in another arm. So this is a specialised procedure. You're nursed one-to-one. It will involve the whole day. It might be a multi-day procedure as well. It's very important that people wear comfortable clothes, bring your phone, bring your headphones, bring a support person, bring an iPad, basically just try and to make yourself as comfortable as possible. We do encourage people to bring their usual medications as well, particularly their blood pressure medication. There is a risk that having the apheresis procedure that it can lower your blood pressure a little bit. And for that reason, at our centre, we actually ask people not to have their morning blood pressure medications on stem cell collection day, but to bring them in with you. Some people may need to have specific heart monitoring that may not be able to be done at an outpatient unit where the stem cell collection process happens. And so sometimes people may need to be moved to a cardiac ward or a cardiac procedure room for the collection to occur. Briefly, citrate, I did mention citrate, so that is a blood thinner. When that does mix, and because we don't want any clots to occur during the collection process, So when the citrate mixes with your blood and is infused back into you, there is a risk of citrate toxicity. And what happens is that the citrate sort of draws the calcium from your bones. And so people can get some side effects, which is mouth tingling around your mouth. You might get a locked jaw. People might get some shin splints or some pins and needles sensations. And that is easily resolved by having a calcium infusion. So transplant specialists aim to try and get enough cells for 2 transplants. And so a minimum dose for a transplant is 2 million CD34 cells per kilo of body weight. And once we have enough stem cells for cryopreservation, they're cryopreserved and stored until we require them. So the time frame between stem cell collection and stem cell transplant can be a little bit dependent on, I guess, people's response from induction treatment. It can be also their transplant decision. Some people may need to have a little bit further induction treatment. Some people may need to do a lot more planning in regard to, particularly if they have to travel quite a considerable distance for their actual transplant. But as a guide, it's usually between 3 to 4 weeks from having stem cells collected to actually proceeding on to your transplant. So high-dose chemotherapy that people receive is melphalan. So briefly, the chemotherapy is given to attack and destroy cancer cells. The action occurs on rapidly dividing cancer cells as well as healthy cells. Our common rapidly dividing healthy cells are our bone marrow, our gastrointestinal tract, and our hair follicles. So high-dose chemotherapy in combination chemotherapy does increase the severity and the duration of side effects. So, for example, if you had your induction treatment, you collected your stem cells off cyclophosphamide, that's one more step up. And the melphalan chemotherapy is another step up in the, I guess, the severity of side effects. So importantly, the stem cell reinfusion aids in rescuing your damaged bone marrow from high-dose chemotherapy. If we don't have stem cells to reinfuse, people cannot proceed to an autologous stem cell transplant. Next slide, please. So this is an example of if someone at our centre was having a transplant as an outpatient. So melphalan is given on day -1. That's very important in regard to coordinating that we make sure it's not on public holidays or the weekend. Day 0 is the stem cell reinfusion. Patients will receive a phone call on day +1 and day +2. Day +3 and day +4, they'll present to our day unit. They'll have a blood test. They may require a blood product transfusion. They'll have a nurse review, a doctor review on our day unit, and then they'll go back to nearby accommodation, where if they live locally, they'll go back home. On day +5, it's the same as day +4, but the plan will be to admit to the hospital. They do start daily filgrastim injections again, or GCSF injections, and these injections are just one injection which help to aid engraftment, so help your stem cells that have been infused on day 0 to engraft back into your bone marrow. So as a guide, discharge follows engraftment recovery, which is around about day +14, which is 14 days post stem cell reinfusion. So to have our, go back a smidge. Thanks, Liam. So for outpatient treatment to occur, a support person is required with the person who's actually having the transplant. It's very important that our accommodation is actually close to the hospital. So with our centre, it's about 30 minutes. And if a support person is not available to stay with the person who's having the reinfusion, then the patient will need actually to be admitted for the whole process. Next slide. Thank you. So day -1 is the conditioning chemotherapy. If not already, people do need to have sessional venous access for the melphalan chemotherapy. This can either be a Hickman line, which is in the upper part of the chest, or it can be a PICC line, which at our centre it's inserted via our vascular access nursing team. The conditioning therapy is given a day prior to the stem cell reinfusion. Do allow about 3 to 4 hours for the treatment on the day unit. A little bit longer if you're having a PICC line inserted on the same day. People get pre-medication hydration. And importantly, just prior to starting melphalan, people will get ice chips. And so it's important, the reason why people get ice chips is to decrease the severity of mouth sores and mucositis. So it's important when having the ice, you just have an ice cube, allow it to melt slowly in your mouth and then get another ice chip. Some centres will do icy poles, and if you're lucky, you might get ice cream as well. Next slide. Transplant day, reinfusion day is day 0. So this will occur, infusion of the stem cells occurs 24 hours after the melphalan chemotherapy. So for example, if you were having melphalan today and the melphalan finished at 1 p.m, we wouldn't be able to reinfuse your stem cells until after 1 p.m. tomorrow. People do get pre-medications and fluid hydration. Occasionally, prior to reinfusion, the stem cell scientists will actually wash the cells, and what they are doing is actually removing the dimethyl sulfoxide or the DMSO cryopreservation agent. And if your people are allergic to sulfur, or they may have some amyloidosis, that just decrease any risk of a possible reaction. So the infusion times vary depending on the number of stem cell bags required, and so that's dependent on how many bags the 2 million or so stem cells are spread into. The infusion, the actual infusion itself is about 5 to 10 minutes. At our centre, if you have a Hickman line, we prefer, as nurses, we prefer a Hickman line because it's a bigger line. If people have a PICC line in, we actually also insert intravenous cannula to infuse our stem cells. As mentioned, stem cells just go over about 5 or 10 minutes. The picture on the screen there is really good. That's basically an example of the colour of what stem cells actually look like. Some other centres will infuse the stem cells through a PICC line, and they actually might use a syringe to infuse the stem cells with. We just happen to don't do that at our centre. So immediate possible side effects are breathlessness, decrease in blood pressure, fever and shivering, flushing, nausea and vomiting, and extreme but rare cases the patient could lose consciousnness. Common side effects of the DMO preservative is a flushed face. They can feel a little bit cold. People can get a tickle in the back of the throat. They can have an unusual taste or smell. What's fairly common is the smell that the patient will have following their stem cell reinfusion. They usually can't smell it, but everyone else in the room and their loved one or their support person will actually smell it. Some people describe it as it smells like tinned cream corn. Some people have mentioned tinned tomato soup. We have one nurse here that thinks it smells like Ribena. I can tell you it does not smell like Ribena. This smell usually lasts for about 24 hours. And the reason why is that the patient who's received their stem cells, the DMSO comes out through the pores in their skin, and they also breathe it out as well. We do encourage to bring lollies in just to try and decrease the risk of the tickle in the throat. And the most common things that I've seen is a slight decrease in blood pressure, a little bit of a tickle in the throat, and of course the unusual smell. With reinfusion process, we do ensure that we have a doctor on the unit. They don't need to be in the same room as the patient, but we just ensure that for safety reasons that we do have a doctor on the unit. Next slide, please. So the common side effects of the conditioning chemotherapy are mucositis, infection, nausea and vomiting, diarrhea, decreased appetite, pain, fatigue, changes in memory and concentration, and hair loss. It is very important, of course, if you patients are an inpatient or even an outpatient, you do start to experience symptoms, do let someone know. If you have had medications for, whether it might be for pain or for nausea, and they haven't been effective, do also let someone know, because there's always something that could be given that's a little bit stronger. Next slide, please. So oral mucositis, of course, is something that is very, very common with chemotherapy. So this involves swelling and inflammation of the lining of the mouth. And this swelling and inflammation does go through the whole digestive system. You can get colour changes inside the mouth. You can get pain while you swallow, while you talk. You can get mouth ulcers. You can also get bleeding from these ulcers. Saliva can be quite thick, or it can actually be non-existent. So treatment is oral hygiene, particularly regular sodium bicarbonate mouthwashes, and also the good old-fashioned salt gargle. Some people may need to have antifungal lozenges or nystatin liquid to help if there's a fungal infection. There's Kenlog gel, which can help with some pain for ulcers, regular pain relief. In extreme cases, some people may need to have a syringe driver that delivers an effective amount of pain relief over a 24-hour period. Good denture care is important. Xylocaine viscus and Mylanta, also noticed that is pink lady, is also quite common, given regularly before meals. Regular lip balm. In extreme cases, some people may need assistance with total parenteral nutrition, which is TPN, or either nasogastric feeding as well. They're not very common, but it is very important as a part of the education process that people are aware that could occur. Next slide. So infection and pancytopenia. So infection, we definitely, there is a huge risk, particularly in neutropenia infection. So like anything, a thorough septic workup would occur. People would go into antibiotics, there'd be blood cultures, there'd be scans. People may need to have additional fluids and electrolytes. Of course, temperatures usually occur on the weekend or very early in the morning. So the staff may initiate a MET call to get some more support available. If you're an outpatient and it's very early on and it's only day +3 or day +4, this is where having a support person does come into factor. If you notice that you do have a temperature, the expectation is that we would get you to present to the emergency department. Blood product replacement, platelet transfusion is quite common. Some people, not many people, but some people can actually go through a transplant and not actually require a blood product replacement or platelet transfusion. It's not very rare though, but it is very rare, but I've come across a few patients that's happened to. As previously mentioned, GCSF injections do start on day +5. Need to definitely consider the patient environment, a single room, be mindful of visitors. Very important to have good hand hygiene. And in some centres, even having flowers in the room is not appropriate. So the lovely little squiggly lines that I've added to this slide is basically a patient who has recently had an autologous stem cell transplant for myeloma. What I wanted to very much bring to everyone's attention is that they had their conditioning treatment on the 20th of February, their reinfusion on the 21st of February. The green line is the person's neutrophil count. And so at on the 26th, which is day +5, you can see that the neutrophil count is a little bit less than 2. And so from day +6 to approximately day +10, that day +11, they were actually neutropenic. So that is, of course, quite common. And what is important is that around that time when people are in hospital, that's when the severity of the symptoms are usually at the worst, that is heightened. And patients have described to me is that when they do get their symptoms, they tend to come in waves. And so sometimes the waves come quite quickly, and then gradually the waves definitely start to come back quite slowly. Next slide, please. So nausea and vomiting, regular dose anti-nausea medication is quite important, and sometimes there's always stronger anti-nausea medication that patients can request. Severe cases, they can have a syringe driver. There is a risk of having dehydration, so fluid and electrolyte replacement is quite important. When patients are an inpatient, they are in our hospital, they're automatically seen by a dietitian. So very much encourage regular small meals, definitely eat slowly, encourage people to sit out of bed for their meals, and not to definitely don't lie down while you're eating. Some people benefit from having peppermint or ginger tea. Diarrhea is a very common side effect. So probably about 80% of people will get diarrhea. It usually occurs from 24 to 96 hours after having the melphalan chemotherapy. One of the first things that we do is we'll send off a specimen to make sure people don't have a bug. If people do have a bug, you'll get some antibiotics to treat that bug. If you don't have a bug, we can give you some medications such as gastrostop or codeine phosphate, just to try and decrease the severity of your bowel motions. So the dietitian's very handy here in the way that you can get onto a special protein diet. So it's just so you can avoid the fatty, creamy and sugary foods. Be mindful of stringy vegetables. I always encourage people to avoid coffee. Coffee can be quite hard on the digestive system, and it actually can make people definitely feel a little bit more queasy. Next slide, please. So fatigue, unfortunately, there's no magic cure for fatigue. Patients feel physically and mentally drained. They have low energy and motivation. People can find it difficult to concentrate. They can have trouble sleeping at night. Some people can actually start to feel a little bit depressed. Very important to pace yourself. Definitely plan ahead. Do break down tasks into manageable goals. Some people find it beneficial to keep a diary. I do have goals and some things to definitely look forward to, and definitely consider physical activity and exercise. Some people can get some memory loss and forgetfulness, and also feel a little bit vague. Definitely, we provide a lot of reassurance with that, and I guess having a calendar, diary, support person is very handy. And in severe cases, some people might need to be referred to a clinical psychologist or an occupational therapist. So I just wanted very briefly to touch on engraftment syndrome. I have seen this recently, which is why I've added it in. This usually does occur following an autologous stem cell transplant. It's characterised by non-infectious fever, weight gain, hepatic and renal dysfunction, skin rash and pulmonary edema. The exact cause is not fully understood, but it's thought to be related to the release of inflammatory cytokines. So it usually occurs just prior or post engraftment. So it's anywhere from about, say, day +9 up to maybe a week, so that day +16, day +17. So there is a slight risk this can occur when a patient has actually gone home. So most cases are really, really mild. It's more common in females, younger females, people who've had minimal chemotherapy, and particularly myeloma patients. If it does occur on a ward, we do the full septic screen workup. They have antibiotics, and if they need to, they'll end up having steroids. So I guess the take-home message is that if people are discharged, it's still very important to definitely keep an eye on your infection risk. And if people do have a temperature, it's very important to present to the emergency department. Next slide, please. So follow-up, as previously mentioned, as a guide, if you're inpatient, it's usually about 2 to 2.5 weeks. At our centre, we do a phone call follow-up, usually within the first week, and depending on how that conversation goes, we end up doing a few more follow-ups. Or if the person actually feels quite good and independent, we actually stop our conversation there, but we usually end up catching up with people quite regularly in the clinics. It is important to have a specialist review 2 to 4 weeks post-discharge. Sometimes in some places that can be a little bit longer. Definitely make an appointment just to say hi to your GP, just to check in to make sure everything's going okay. Maintenance treatment can be commenced, and usually that starts about 2 to 3 months after a transplant, because we want people to recover from their transplant. People are eligible to have their vaccinations as per the immunisation schedule, and these start from about 6 months following a transplant. Depending on where you live, some may be incorporated within the health service, and some, unfortunately, you may have it out of pocket expense for that. Very important also to continue having regular flu jabs and be revaccinated against COVID. We can't make people be revaccinated, but if it's something that you are considering, I would definitely encourage to have hepatitis B and the respiratory revaccinations. Just another little plug here for the support groups and services. There's some people that, although we educate, just go back a smidge. Sorry, Liam. Some people who we actually support haven't actually felt comfortable to be referred to support groups. So sometimes it is a time where some people actually do definitely do that. In regard to returning to work, very much I try and encourage people to have at least recover for about 4 to 6 weeks. Some people do need to have the stress of actually needing to return to work for financial reasons. And if people do need to return to work, it's very much to engage in a safe return to practice and actually start off quite slowly. And just to finish up, definitely fatigue management. Everyone manages fatigue differently. Physiotherapy and exercise, I know that there was a discussion prior to that, that's really important to definitely focus on. And at the end of the day, I don't have the answers for fatigue, but gradually people will realise that they'll find out that they might be better in the morning compared to the afternoon. And so in regard to thinking about returning to work, people may realise, they might have to do work in the morning. Usually around the 6-week mark after transplant, most people start to feel that little bit better and that little bit stronger. But at the end of the day, it is an individual process. And I think that's it. There's some references there. Definitely check out the myeloma website if you haven't already. EVQ is Cancer Treatments Online, is where there is a lot of protocols. I think the next slide's the reference list, which you don't need to worry about that. And then the last slide's some 90s version of stem cell collection, the chemotherapy and the actual transplant. So that's it. I'm very sorry I've probably spoken too much, but there is a lot of information to try and get in.
Thanks very much, Jenny. That was very comprehensive. In fact,
I'm
it was
so sorry.
comprehensive. We don't have time for questions, but as mentioned previously, if anyone does have any questions, please feel free to email us, and if we can answer them, we'll certainly help. Otherwise, we'll forward them on to whichever speaker they're directed at.